Hi everyone, I am Dr. Akanksha Kashyap, Senior Lecturer, Department of Periodontology, BBDCODS, BBD University, Lucknow. So today we will be discussing about the radiographic aids in the diagnosis of periodontal disease. So why do we need radiographs in periodontics? We need them for the diagnosis of the periodontal disease and to estimate how severe the disease is, then to determine the prognosis of the disease. So prognosis, it is the prediction of the probable course, duration, and outcome of the disease. And then the radiographs are used for evaluation of the treatment outcome. But it should be remembered that radiographs, they are an adjunct to the clinical examination. They are never a substitute for it. Why? Because radiographs, they demonstrate changes in the calcified tissues. And regarding periodontium, the calcified tissues consist of alveolar bone and cementum, and they do not demonstrate the changes in the soft tissues of the periodontium. Also, they do not reveal the current cellular activity, but rather they reflect the effect of the past cellular experience on the bone and roots, which means that the periodontal destruction, it is a cellular process. So this cellular destruction, in this there is release of inflammatory mediators by the inflammatory cells. So these inflammatory mediators, via the pathway of inflammation, they start destruction in the soft tissue. Like from gingiva, the inflammatory mediators, they move on to the periodontal ligament, then to the cementum, and finally the destruction reaches the alveolar bone. So initial clinical changes, they're always seen clinically. Now, normal interdental bone. So whenever the bone changes in the periodontal disease are whenever we want to see the bone changes in the periodontal diseases radiographically, it is always assessed on the basis of this interdental bone. So why not the buccal and the lingual bone? Because the buccal and the lingual bone, they are usually obscured by this thick and dense root structures. So that's why we usually look for the bony changes in the interdental bone. So this interdental bone, as you all can see, it is lined by a thin radio-opaque line, this white line. It is known as lamina dura, or it is also known as alveolar bone proper. So this basically, it is the internal cortical plate, the internal cortical bone. So it has sieve-like openings or cribriform plate through which the neurovascular bundles, they communicate from the periodontal ligament to the inner cancellous bone. So this lamina dura, so there is a considerable variation in its appearance. So this lamina dura, it appears according to the shape and the convexity as well of the root. Also, it depends upon the angulation of the X-ray. Now, the topmost portion of the interdental bone, it is known as crest of the interdental bone. So the width, now talking about the width of the interdental bone, so it depends upon how the convexity of the approximating roots and the angle. So this is the angle of the crest of the interdental bone. So it is parallel to a line which connects the CEJ of the approximating teeth. So can you appreciate this junction? So this junction, which can be easily appreciated. So this is the enamel, this is the cementum, and this is the CEJ, cemento-enamel junction. So the angle of the interdental bone, it is usually parallel to this CEJ, to a line connecting the CEJ. So if the CEJ of the approximating teeth, they are at the same level, so it will be almost horizontal. But in this case, like we can see, the CEJ are at a different level. So this bone appears angulated. The interdental septum it appears angulated. This is what I'm talking in healthy periodontium when there is no bone loss. Now that was about the mesiodistal width. Now talking about the faciolingual width of the interdental bone. So it depends upon the width of the root surfaces, how wide the root surfaces are. Now the radiographic techniques. So for periodontal evaluation, so basically we use two types of techniques, which are periapical and bite wing projections. The periapical, which is also known as IOPA, intraoral periapical radiographs. So why these two? Because they offer the most diagnostic information from the periodontal point of view. So Pritchard, in 1972, he established 4 criteria to determine the adequate angulation of the periapical radiograph. So according to these criteria, the appropriate, if the IOPA for IOP, the appropriate angulation should be such that when the radiograph should show the tip of the molar cusps with minimal or no occlusal surface. Then the enamel caps should be distinct, the pulp chamber should be distinct, then the contact areas, they should be open, because I told you that we normally assess the interdental bone. The interdental bone is assessed for the level of the bone loss. So if there is crowding or the proximal contact area, they overlap, so it will be difficult for us to assess the bone level. And then the proximal contacts, they should not overlap until unless the teeth are anatomically out of occlusion. So when talking specifically about the periapical radiographs, so we you all must have read that we use two techniques, the long cone paralleling technique and the bisection of angle technique. So the long cone paralleling technique, this most accurately projects the alveolar bone level, which is what we require for periodontal diagnosis. But there's another technique which is bisection of angle, which leads to elongation of the projected image. So if the image is elongated, so this makes the bone margin appears closer to the crown structure. So then the bone loss or the bone levels are underestimated. So like you can see here, the figure A and B, these are the X-rays which are taken by long cone paralleling technique, while C and D are the periapical radiographs which are taken by bisection of angle technique. So here you can see that as I've already discussed, that the buccal and the lingual bone margins, they are difficult to appreciate on the periapical radiograph. For that matter, this is a dried bone specimen. So here you can see the smooth wire. So this smooth wire, it is placed on the buccal bone margin, while this knotted wire, you can see the knots here. So this knotted wire, it is placed on the lingual bone margin. So when both the techniques are compared, you can see, so it can be appreciated that the bone margins, both the bone margins, they appear to be closer. Like this is by long cone paralleling technique, and this is by bisection of angle. So here you can see the bone margin, it appears shifted more towards the crown surface. So this basically it underestimates. So this underestimates the amount of bone loss. Now with periapical radiographs, so they have their own limitations, that they do not reveal the correct relationship between the alveolar bone and the cemento-enamel junction. So in particular cases where there is shallow palate or where the floor of the mouth, it does not allow the ideal placement of the periapical film. So in those cases, we can go for bite wing projections. They offer an alternative. So in bite wing projections, as you can all see, both the maxillary as well as the mandibular arches, they can be filmed together. And for this, the film is placed behind the crown of the maxillary as well as the mandibular teeth. And then the X-ray beam, it is perpendicular to the long axis of the film, and the beam is passed through the contact areas. So this bite wing projection, it leads to the evaluation of this relationship between the alveolar bone and the CEJ without distortion. So here you can see, this is the periapical radiograph, and this is the bite wing radiograph. So in periapical radiograph, the beam is at an angle to the film, and this is the actual distance between the alveolar bone and the CEJ. But because of this angulation, this distance, as you all can see, it is distorted. While this is a bite wing radiograph, here the X-ray beam is perpendicular to the film. So this distance, this is the actual distance, and this is the distance which has been measured by this technique. So this is almost accurate. So they allow a more accurate depiction of the distance. So like here you can see these white arrows, they tell us about the amount of bone level. So here you can see this is the periapical radiograph, this is the bite wing radiograph. So the periapical radiograph, so this clearly it underestimates that this is the bone loss. This is the actual bone loss, and this is the bone loss which is being shown in the periapical radiograph. So this periapical radiograph, it actually underestimates the amount of bone loss. So whenever you are asked that which is the preferred imaging technique to depict the periodontal bone level in the posterior teeth, so we should always answer the bite wing. So it is always a preferred technique. Now coming on to the bone destruction in periodontal disease. So for bone loss to be evident on a radiograph, so a sufficient amount of mineralized tissue needs to be removed. Only then the bone loss can be captured on the radiograph. So therefore, this, if you see a slightest amount of radiographic changes on the of the periodontal tissue on the radiograph, so this suggests that disease has progressed from its early stages. As already discussed, the earliest sign of the periodontal disease, they must always be detected clinically. So we cannot see if the disease is in an active state or the disease or the patient is treated from a radiograph. So we always have to examine the patient clinically. So bone loss, the radiographic image, it tends to underestimate the severity of bone loss. So basically there is a difference between the alveolar crest height, the actual height of the alveolar crest, and the height which we can appreciate or which we can see on the radiograph. So this difference, because of X-ray angulation, it is from 0, it can be accounted from 0 to 1.6 mm. So because of the difference in the X-ray angulation, so there is a difference in the actual height as well as the height which we can see or which we can appreciate on the radiograph of the alveolar crest. And radiographs, they are an indirect method for determining the amount of bone loss. Why? Because they do not tell us about the amount of bone which has been lost. So we cannot measure the amount of bone which has been lost, but we can see the amount of remaining bone. And certain studies are done. According to those studies, a normal distance of about 2 millimeter between the CEJ and the alveolar crest, it reflects the normal periodontium in adolescents, and in the older patients, the disease may be greater. The distance may be greater. Now coming on to the pattern of bone destruction. So there are basically two patterns of bone destruction. Firstly, it's horizontal, and then it's vertical or angular bone loss. In horizontal bone loss, you can see here, this is the horizontal bone loss. Here you can see the height of the bone is reduced. The height of the bone is reduced, and the long axis of the tooth, it is perpendicular to the crest of the interdental bone. So this is the crest. I told you crest is the topmost part of the bone. So the interdental bone, so the crest of the interdental bone, it is perpendicular. This is the long axis of the tooth. So it is perpendicular to the long axis of the tooth. So this is horizontal bone loss. As you can see here, horizontally, the bone loss is in a horizontal pattern. But when there is bone loss and the crest of the interdental septum, it is at an angle to the long axis. This is the long axis of the tooth, and you can see that crest is at an angle to the long axis. So this is angular or vertical bone loss. Now we have certain limitations of the radiographs. Example, the radiographs, they do not tell us clearly about the morphology and depth of the crater-like defects. Also, they do not reveal the facial and the lingual bone surfaces, as already discussed, because the facial and the lingual bone surfaces, they are obscured by the dense root structures. So in those cases, normally if we see that interdental bone loss is there, we assume that this bone loss, it might extend either in the facial or in the lingual direction, which leading to the trough-like lesion. Trough is a concavity, a depth-like lesion. So we assume that if interdental bone loss is there, so there automatically will be facial or lingual bone surfaces. They must be involved. Also, in certain cases where you can see the mylohyoid ridge is dense. So in those cases, so the mesial and the distal root surfaces, they may be partially hidden because of the dense ridge and the destruction. It could be hidden in those cases. And also, periodontal bone loss, it should be differentiated from anatomical variation that resemble the disease. Like here, we can see we can see the radiolucencies here. So we cannot easily make out what is this radiolucency. Is this actually bone loss, or it is some anatomical variation? So it is very difficult to differentiate these on the radiographs. Like here, these are the nutrient canals. So these nutrient canals, basically, these are the foramina which carry the blood vessels. So these nutrient canals, they can appear as linear and circular radiolucent areas, and these are seen more commonly in the anterior mandible. So in radiographs, it is sometimes very difficult to differentiate them from the periodontal disease. Also, the differentiation between the treated versus active periodontal disease can only be achieved clinically. As I've already discussed, if we see a radiograph where there is bone loss. So we cannot judge from the radiograph if the patient is having the active disease or the patient has been treated. Why? Because if the disease is active or not, we cannot see from the radiograph. So we always have to go for the clinical examination. We will have to have a look in the clinical condition of the gingiva. We will have to see if the patient is having inflammation, if there is bleeding on probing, there is ulceration. So this radiograph, it cannot differentiate between the active disease or a patient who is maintained. But if we see a detectable amount of changes in the normal cortical outline of the radiograph, so it definitely means that there is destructive periodontal disease. So now coming onto the radiographic appearance of periodontitis. So the radiographic changes in the periodontitis, they appear the normal pathophysiology of the periodontitis. So the first and the earliest sign, the earliest radiographic change is there is fuzziness or there is break in the continuity of the crestal lamina dura. So as I've told you, this is the lamina dura. So there is there is discontinuity in the crest of the lamina dura. So why does this occur? So this occurs as a result of bone resorption because of extension of the inflammation into the alveolar bone. So now it should be remembered that if the crestal lamina dura is intact, if you see that the intact crestal lamina dura, so it always indicates that the periodontium is healthy. But if the crestal lamina dura is not intact, it does not always mean that the periodontium is diseased. Why? Because no correlation has been found between the crestal lamina dura and the clinical signs of inflammation, bleeding on probing, and periodontal bone loss. So then after that, as the bone loss continues, there is widening of the periodontal ligament space, which leads to the formation of wedge-shaped radiolucency. So you can see here, this is the widened periodontal ligament space, and there is formation of widened space, and there is formation of a wedge shape. Wedge means a triangular shaped radiolucency on the mesial and distal aspect of the crest. Further, there is subsequently bone destruction process, it increases, then the height of the bone decreases, and then finally there is severe bone loss. So the radiolucency increases, you can see, and there is severe bone loss. So frequently we can appreciate a horizontal radio-opaque line. So this radio-opaque line on the root surface, so this demarcates the area on the root surface where bone has been denuded or bone destruction has occurred from the area where the bone support is remaining. So this is the area where the bone support is remaining, and in this area, the facial as well as the lingual bone, they have been destroyed. The bone has been destroyed. Now coming on to interdental craters. So these interdental craters, basically, they are the concavity or they are the bone defect which leads to formation of concavity on the interdental septum. So these craters are areas of irregular reduced density. These are basically irregular areas of reduced density, and they are not very sharply demarcated, and they gradually blend with the remaining bone. So as I've already told you that this is the limitation of the conventional radiograph, that they do not accurately depict the morphology of the craters. But sometimes we can see they appear as vertical defects on the radiograph. Now, radiographic appearance of furcation involvement. For furcation involvement, the definitive diagnosis is made by clinical examination, which is done by a specially designed probe, that is Neighbors probe. But radiographs are helpful, but there can be root superimposition, which can be caused by anatomical variation or because of improper technique. So in those cases, which can obscure the radiographic representation of the furcation involvement. So as a general rule, it has been told that the bone loss is always greater than it appears in the radiograph. So for furcation involvement, for the diagnosis of the furcation involvement radiographically, the radiographs, they should be taken at different angles. As a tooth, they may present marked bifurcation involvement in one film, but on the other film, it can appear as completely uninvolved. So like here, you can see in the bifurcation area of the first molar, so there is a very clear evident translucency, so which indicates that the furcation is involved. While in the furcation area of the second molar, there is only slight thickening of the periodontal space. So when the same area is filmed at a different angle, So here you can see this translucency, which was evident here in the bifurcation of the first molar. So this is obliterated. We can't see it. We can't see it very clearly. But now the second molar area, you can see there is. It needs to be. It is seen to be more. Apparently, it is more involved. The bifurcation is involved. It is more evident here. And to assist in the radiographic detection of the furcation involvement, so following criteria are suggested. So whenever we see a slightest amount of change in the radiograph, in the furcation area, so in that cases, it should be investigated clinically. Also, when there is a clear diminished radio density in the furcation area, so it means that the furcation is involved. And whenever there is marked bone loss in relation to a single molar tooth, like here you can see there is marked bone loss in relation to the distal root of the first molar. So in those cases, we can assume that the furcation is involved. Like here, this furcation involvement is there with respect to first molar, but it is partially obscured because of the radio opaque. This is the radio opaque lingual root. So because of this, the furcation involvement is masked. So clinically, we have to assess furcation involvement along with radiographic examination. So now coming on to the periodontal abscess. So periodontal abscess, it appears as discrete area of radiolucency along the lateral surface of the root. Like you can see the area of radiolucency along the lateral surface of the root. So however, the radiographic picture is not very characteristic for periodontal abscess. Why? Because it depends upon the stage of the lesion. The periodontal abscess in the initial lesion, although it is very painful, but it is not evident on the radiograph initially. Also, it depends upon the extent of the bone destruction and the morphologic changes of the bone and the location of the abscess. So if the abscess is in the soft tissue, so it is very difficult to be appreciated on a radiograph. Because I've told you the radiograph, they do not very clearly capture the changes in the soft tissue. And also if the destructive lesion is in the buccal or the lingual bone, then also it is very difficult to be appreciated on a radiograph. But if the lesion is involved in the interdental bone, so then it can be clearly visible on the radiograph. So radiograph alone, they cannot provide a final diagnosis of a periodontal abscess, but they need to be accompanied by careful clinical examination. Now, what are opaque pointers? So whenever we plan a regenerative or a resective flap surgical procedures, so we want to know how the osseous topography of the bone is. For that, we carefully do the probing or the bone sounding after anesthetizing the area. So in those cases, so we can anesthetize the area and then we can put some pointers which are opaque. So if they are opaque, they can easily be appreciated on the radiograph. Like we can put gutta percha points, or we can put Hirschfeld pointers, which are the indicators through the sulcus in the anesthetized pockets and this areas, and then we can take the radiographs. So then this can actually tell us about the true extent of the bony lesion. Now coming on to the radiographic changes in localized aggressive periodontitis. So the localized aggressive periodontitis, it basically involves the bone loss in the maxillary and the mandibular incisor areas and the first molar areas. So the radiographic appearance is typically, there is vertical bone loss. It is typically arc-shaped when talking about the localized aggressive periodontitis. So there is typical arc-shaped bone loss. So this arc-shaped bone loss, it extends from the distal surface of the second molar. So it extends from the distal surface, then it follows an arc-like pattern and it extends up to the mesial surface of the second molar. So as the disease progresses, so there is loss of the alveolar bone and it may become generalized, but it remains it remains less pronounced in the premolar area, more pronounced in the molar as well as the incisor areas. So here you can see that there is accentuated bone destruction in the first molar as well as the anterior region. This is the anterior region and the first molar. Basically, there is vertical defects. There are vertical defects in aggressive periodontitis. Now coming on to trauma from occlusion. So for trauma from occlusion, the radiographic changes are not very pathognomic and they must be interpreted in combination with the clinical findings like tooth mobility, and we should look for wear facets and if the pocket is present or not. And also then the appropriate occlusal contact analysis should be carried out. So in the injury phase of the trauma from occlusion, so it produces a loss of the lamina dura. You can see there is loss of the lamina dura, and it is more noticed in the apices in the furcation areas and in the marginal areas. Then in the repair phase, where there is an attempt to strengthen the periodontal structure. So there is, because of the loss of the lamina dura, there is widening of the periodontal ligament space, which can either be generalized or could be localized. And when there is more advanced traumatic lesion, so then this may result in formation of the deep angular bone loss. And when combined with the marginal inflammation, it leads to the formation of marginal inflammation. So when there is a zone of co-destruction. So in those cases, only in those cases, there could be intra-bony pocket formation and trauma from occlusion. Otherwise, there is no pocket formation. And in terminal stages, root resorption can be seen. Now coming on to the advancements in the radiography. So firstly, it is digital intraoral radiography. So digital is computerized radiography. So it is a very convenient alternative to the conventional film-based radiography. Why? Because it maintains fully electronic patient records. So here you can say this is the image display of full mouth radiographic series by digital intraoral radiography. So the digital system, it uses solid state detectors and phosphostimulable phosphor plates. So the solid state detectors, it uses image receptors, which are charged coupled devices or complementary metal oxide semiconductor chips. So these image receptors, they are wired and they are connected to a computer using the USB, and then the images are recorded and they are displayed on the computer. So following capture, so there are many advantages of the digital radiography, that once we have captured the image, so the images, they can be enhanced to augment the radiographic diagnosis. The brightness and the contrast, it can be altered. The images can be magnified. Like here you can see the Perio image enhancement filter has been used to highlight the contrast of the alveolar bone. For the periodontal diagnosis, we basically need the level of the alveolar bone. So now, because of the enhancement filter, we can more clearly appreciate the alveolar bone. So now in this radiograph also, we can appreciate that the calculus is, and it is much better depicted, and the alveolar crestal bone is also better. Depiction is better than the conventional radiography. So in addition to the image manipulation feature, it facilitates in the patient education, it facilitates in the easy storage of the radiographs, and the sharing can be done with other healthcare providers. Now coming on to the CBCT, that is cone beam computed tomography. So it is a three-dimensional, accurate three-dimensional imaging technique. The conventional radiograph, or the OPG, they were the two-dimensional imaging technique. CBCT, it is a three-dimensional imaging technique. And so it avoids the problem of superimposition or unpredictable magnification of the conventional radiographs. Why? Because it clearly depicts the buccal, lingual, and the palatal surfaces also. For example, if there is a 3-wall defect that preserves the buccal or the lingual cortical plates, that can be difficult to diagnose on the conventional radiograph. So, but it can be seen clearly in a CBCT. Also, the furcational areas and in the furcation area where the bone loss assessment is very difficult. So that is more convenient by the use of CBCT. So it adds diagnostic value. So here you can see figure A is perioapical radiograph, while B, C, and D are the CBCT images. So this perioapical radiograph in relation to 3-2, it shows the normal bone level. It does not show any type of bone destruction. While B, C, and D, here you can appreciate that 3-wall defects are present. 3-wall means 3 walls are remaining. So these 3-wall defects, they can easily be appreciated on the CBCT sections. But CBCT, it is a higher dose procedure and is also more expensive. So it is considered it is not considered in each and every case. So it is considered in selective cases only. And this is not recommended in routine evaluation of the periodontal bone loss. So in the end, we can conclude that The periapical radiographic examination, it should be a part of every patient's periodontal evaluation and should always be coupled with a detailed clinical examination. The radiographic evaluation, it should be updated every 2 years. If the patient is on a follow-up, if the patient is, you're following up the patient, so every 2 years, you should always do the proper radiographic evaluation of the patient. The periapical radiographs, they always, as I've discussed, that they underestimate the total amount of bone loss, and significant interdental bone loss can occur and may not be detectable on IOPA. This is discussed that because of the because the buccal and the lingual cortical bones, they are usually obscured. So for that, three-dimensional radiographic techniques like CBCT, so they give more accurate picture of the periodontal defect, but and will be more widely used as the technology becomes available in more clinics. Thank you.